Hello everyone, welcome once again to Words Made Easy. My name is Dr. Beston Mwila, and today we're going to be finishing up our discussion on DKA, and we're going to be talking about the management of diabetic ketoacidosis in children. So we're going to start off with the management of DKA in children, and then we'll talk about the management of DKA in internal medicine in another video. Okay, so if you haven't subscribed to my YouTube channel, please subscribe, hit the like button, and share with your friends so that you are able to see this content, so that your friends are able to benefit as well. Okay, with that being said, let's begin. We're behind time already. Okay, so how do we manage diabetes DKA in pediatrics? Okay, so the management of DKA follows certain principles. So we need to resuscitate. Remember that DKA is an emergency. So because it is an emergency, it's a medical emergency, we need to resuscitate. So we start off with a resuscitation, resuscitate, and then we'll deal with the fluids, insulin, potassium, we correct the acidosis, and antibiotics. I think we talked about the principles of management in the previous video. If you haven't, if this is the first video you're watching on DKA, please go back and watch the previous video that we did on DKA to have a better understanding on what DKA is, and then you can come to the management as well. Okay, so this, if you want to remember the management, you can even use the mnemonic, and I'll teach you the mnemonic that you can use in a bit. So we begin with resuscitation. So remember that DKA is a medical emergency. So now because DKA is a medical emergency, this patient needs to be resuscitated immediately. So once DKA is diagnosed, you need to resuscitate this patient using your ABCs. So using your A, B, C, Ds. Okay, you use your ABCDs to resuscitate. So A is for your airway. So you're going to do your airway management. Make sure that the airway is patent. Okay, make sure that the airway is patent. So this is your airway. So make sure that the airway is patent. Okay, make sure that the airway is patent. Make sure that the airway is patent. If there are any secretions, you are going to suction the secretions. Okay, you are going to suction the secretion. If the patient is comatose and recently vomited, you will need to insert an NGT. Okay, you may need to insert an NGT so that you protect the airway. Remember that this patient can easily aspirate. So if this is a patient who vomited, they may aspirate, so you may need to insert an NGT in such a patient. The B is for breathing. So the B is for breathing, okay, ABC. So your B is for breathing, So ensure that the patient is breathing. So how do you do that? Check if the chest is moving, okay, chest movements, check the chest movements, count the respiratory rate, okay, check your SpO2 and put this patient on 100% oxygen, okay. So put this patient on 100% oxygen. So that is how you are going to do. That is your B, okay. So you put this patient on 100% oxygen. If this patient is apneic, you are going to give O2. You are going to give bag mask valve, a BMV ventilation, okay. Bag and mask ventilation, okay. You can use your BMV, okay, bag mask valve, okay, which is what you use if the patient is apneic. Okay, then the C is for circulation, okay. The C is for circulation. So C is for circulation. So the C is for circulation. So what do you do under circulation? You are going to double cannulate, okay. You are going to double cannulate, obtain IV access, okay. Obtain IV access. So you double cannulate this patient, and as you cannulate, when you're done cannulating, draw samples for labs, okay. Take the blood, draw samples for labs. That's where you're going to do all those laboratory investigations that we talked about. Okay, your FBC, DC, that's why you're going to do your U and E's, creatinine, you're going to do your renal function test, your liver function test, and all those necessary, your ABGs, they are going to come from the blood that you have withdrawn, that you're sending for the labs. Okay, and when you collect those samples that you're sending for the labs, okay, this is where you're also going to make sure you assess this patient. Okay, what are you going to assess? Check your heart rate, okay, check the BP of the patient, okay, check the capillary refill time, okay, check the peripheries, are they cold, okay, the periphery is cold, okay, and these are going to help you determine whether the patient is going in shock or not, okay. So if you find that this patient is in shock, in pediatrics, because in some patients you may not be able to take the BP in pediatrics. So what to tell you that this patient is going in shock in a pediatric patient, usually you are going to look at the capillary refill time, which is going to be delayed above 3 seconds, okay. The capillary refill time usually may be delayed above 3 seconds. The other parameter that you use is you're going to have a rapid pulse, okay, a rapid heart rate, okay, capillary refill time greater than 3 seconds. You have a rapid heart rate, okay, you may have a rapid heart rate, okay. The other thing is that you can look at apart from that is the peripheries may be cold, okay. You may have cold and clumsy peripheries, okay, peripheries. Okay, so once you find this capillary refill time, delayed, rapid pulse, cold and clumsy peripheries, this may show you that this patient is in shock. So if the patient is in shock, what are you going to do? If the patient is in shock, you resuscitate with 20 mils per kg body weight of normal saline. So you are going to give normal saline at 20 mils per kg body weight. So this is 0.9%. 0.9% normal saline. So you are going to give this patient normal saline 0.9% as quickly as possible, okay, as a bolus. And then you are going to repeat as necessary, as needed. You repeat the boluses as needed, but not exceeding. You don't exceed 60 mils per kg. So you don't exceed 60 mils per kg. So if you find that this patient is in shock, you are going to start off with the treating this patient, treating the shock as per shock protocol. So we are going to give 20 mils per kg of normal saline, 0.9% normal saline, not exceeding 60 mils per kg of normal saline. Make sure you also catheterize this patient. Remember, I was still on circulation. Okay, to also monitor how much blood flow is going to the kidneys, you also catheterize this patient. So catheterize to monitor the urine output of this patient, okay? Monitor urine output. Remember, the DKA can send you into dehydration, and that dehydration itself can actually lead to prerenal acute renal failure. And so you want to monitor the urine output, and you need to catheterize for you to do that, okay? Then the D is for disability. Okay, so this is number 1, this is number 2, number 3, and number 4, we have the D, which is disability. So the D is for disability. This is where you check your GCS. So this is where you're going to assess the level of consciousness. So you assess the level of consciousness using the Glasgow Coma scale. So that is how we are going to resuscitate this patient who has DKA. So that is the resuscitation of this patient. So let's move on to the fluids now. Okay, let's move on to the fluids. So after resuscitation of the patient, after the patient is resuscitated, you start your fluid management. If the patient, so you start off with the resuscitation, then you move to the fluids. So fluid management. So remember the second, this is a mnemonic that you can use after resuscitated. The mnemonic that you can use to remember the principles of the principles of management of diabetes ketoacidosis is FIPA. So you can use this mnemonic. FIPA. FIPA. So F is for fluids. So correct dehydration using IV fluids. The I is for insulin, correct hyperglycemia using insulin. The P is for potassium, correct electrolyte imbalances. The A is for acidosis, correct the acidosis. And the other A is for antibiotics. So administer antibiotics. So treat infections, treat intercurrent infections if present and if indicated. Okay, if present. So that is the other A. These are the things we're talking about. FIPAA. So we start off with the fluids. So fluid management in pediatrics, in a pediatrics patient, we do fluid replacement. So we want to give our fluids to replace. So this is fluid replacement. Okay. So we give replacement fluids because this patient our patient has lost a lot of fluids and we want to replace that fluid. So fluid replacement, the fluid of choice we're going to be giving this patient is 0.9% normal saline. Okay, so choice of fluid is 0.9% normal saline for volume expansion. So that is the fluid of choice. Fluid of choice 0.9% normal saline. So the infusion of isotonic saline is important because number one, you want to give normal saline because it will help you to expand the extra cellular volume and stabilize the cardiovascular status of the patient. Remember, this patient's extracellular volume or the circulatory volume is diminished, is depleted because of the polyuria. Okay, the polyuria, the vomiting, they are losing fluids, and that is depleting their the extracellular intravascular fluid. So you want to stabilize the cardiovascular status of this patient. Number two, fluids are important because remember that as you lose fluids, you are going to remain with a high osmolarity. And we said in DKA, osmolarity can go as high, can even be above 290 milliosmoles. So what we want to do is we want to lower plasma osmolarity. So we give fluids to lower plasma osmolarity. The other thing is that we want to reduce on the vasoconstriction. So when we reduce on vasoconstriction, we're going to improve on perfusion of organs like the kidneys. The fourth reason as to why it's important to infuse isotonic saline is because we're going to it helps us to reduce on the levels of these stress hormones that are already in circulation. Remember, these counter-regulatory hormones are a lot. They are flowing in circulation. So as we give fluids, we are going to be able to reduce the levels of these particular hormones in blood. And that is why we give the fluids. So what amount of fluid? So we're giving, this is fluid replacement. Okay, so fluid replacement, how is it done? We're going to give, so fluid replacement, we want to know how much is required. How much fluid does the patient require? So requirements, so fluid requirement can be calculated. Fluid requirement can be calculated by adding the maintenance plus the deficit. So deficit plus maintenance. So deficit plus maintenance, it gives us the amount of fluids we're going to give to resuscitate this particular patient. So the maintenance fluid, I'll start with the maintenance. How do you calculate the maintenance? You can calculate the maintenance using the Holy-DeSega formula. Okay, and that is going to be, maintenance fluid is going to be where you say 100, so 100 mils. So I'm going to say 100 mils, okay, for every 10 kgs. So I'm going to be getting every 10 kg, right? So the first 10 kg times 100 mils. So 100 mils multiplied by the first 10 kg, okay, times 100 mils, then 50 mils times the next 10 kg, okay, the next kg, okay, you multiply by 50, and then 20 mils, okay, 20 mils multiplied by 20 mils times every kg thereafter. So you say 100 mils times 10 kg plus 50 mils times the next kg, 10 kgs, and 20 mils times every kg thereafter. So when you add this, the answer here plus answer here plus answer here, it gives you the total maintenance fluid. Now this total maintenance fluid that is going to be, you are going to get, is supposed to be administered within 36 to 48 hours, okay? 36 to 48 hours. So we'll talk about that. So the answer you find here should be administered in 48 hours. Should be administered in 48 hours. So that is how we are going to calculate. But then how do we find the deficit? How do we find the deficit? Okay. So your deficit is basically how much the patient has lost. So how much has this patient lost? So usually you use 10%. So we usually use 10% which denotes severe dehydration, because most of the patients will come severely dehydrated. So we use 10% as the deficit in managing DKA. So 10% is what we're going to be using as deficit in patients that come in with DKA across the board in pediatric patients. 10% as a deficit. Now, when you find the deficit is supposed to be it's percentage dehydration, which is 10%. Okay, so this is the 10% is percentage dehydration. Okay, so it's like percentage dehydration. So you do your percentage dehydration. Deficit is percentage dehydration, and so it's your percentage dehydration times the body weight. So your body weight multiplied by the percentage dehydration. Okay, your body weight multiplied by percentage dehydration. So percentage dehydration we're going to be using usually it's 10%. That's what we'll be using as a percentage as our percentage dehydration, because it's severe dehydration. Okay, remember that when you check for the for dehydration status, if you those that have some dehydration, usually the percentage dehydration is less than 5%. Those that have no dehydration may be below 5%. Then 5 to 10% for those that have some dehydration, and 10 and above for those that have severe dehydration. But then in this case, we assume they have severe dehydration, so we give percentage dehydration becomes 10%. Now this deficit, when you calculate the deficit, it's supposed to be given in 24 hours. So deficit is given in 24 hours. Okay. Oh, sorry. Deficit is given in 48 hours. So I mixed them up. So deficit is given in 48 hours. So it's actually deficit given in 48 hours. So your deficit should be given in 48 hours. And your maintenance, the maintenance that you find is given in 24 hours. Is given in 24 hours. So maintenance, when you calculate, is given in 24 hours. When you calculate the deficit, is given in 48 hours. Okay, so that is something you should keep in mind. Okay, keep that in mind. Now I'll give an example of how you calculate. So when you add the deficit plus the maintenance, that's the amount of fluids that you are going to give in this patient in 24 hours. Okay, so let me give an example. I hope you've understood this. So let me give an example of a patient who comes in with DKA. Let's try to work out something so that we understand clearly. So let's say this is a 25 kg patient. So the weight of the patient is 25 kg. And this patient who's 25 kg has come in with a DKA. So how are we going to administer the fluids in this particular patient? So we say maintenance fluids for a 25 kg is, we're going to say, so we get 10 kg from here, we say 10 multiplied by 100 mils plus, when we get 10 kg from 25, it remains 15. There's another 10 kg we can get, which is 10 multiplied by 50 mils plus, when we get this, from this we remain with 5, which means it's 20 mils times 5, okay, times 5 kgs. So 10 multiplied by 100 mils, that is 1000 mils, plus 10 multiplied by 50 mils, that is 500 mils, plus 20 multiplied by 5, that is 100 mils. So the maintenance fluid you are going to give in this patient is going to be 1600 mils. So this is what the patient is going to receive as maintenance, and this is going to be given over 24 hours. So the maintenance fluid is 1600 over 24 hours. But what is the deficit? Because the formula is maintenance plus deficit. So for deficit, we say percentage dehydration, which we've said is 10%. So 10%, so because it's a percentage, we're going to say 10% is as good as saying 10 over 100 Then we multiply by the body weight, which is 25 kgs. Okay, 25 kgs. And this is going to give us what? When you say 10 over, when you say 10 over 100 multiplied by 25 kg, I believe this should give us, okay. So this is, calculate here, okay, this is like 0.5, so this should give you about 2.5. Okay, it should give you about 2.5. So this 2.5 is in liters, so that is as good as saying 2.5 liters. Okay, it's good as saying 2.5 liters. So when it gives you 2.5 liters here, because we multiplied here, it gives you 2.5 liters. This is supposed to be given in 48 hours. Okay, so because this is supposed to be given in 48 hours, this is in 24, you can't add this. So what are you going to do? You are supposed to do what? You are supposed to divide this into 2. You divide it by half. So convert this into mils, okay, because that is 2.5 liters. Okay, that is 2.5 liters. The 2.5 liters is as good as saying 2,500 mils. So 2.5 liters is as good as saying 2,500 mils. So this 2,500 mils, because it's in 48 hours and you want to add it to what is in 24 hours, you divide it by 2. We divide it by 2, and this gives us 1,250 mils. Okay, that should give us 1,250 mils. Okay, if my mathematics is correct. Okay, 1,000. So this 1,250 mils is what you add. So this is now in 24 hours. So what are you going to do? You say now we are going to say 1,250 mils, which is the deficit, plus maintenance, which is plus 1,600 mils. So the total that you are going to find when you add this is the amount of fluids that you are going to give. So when you add this, you find somewhere 2,850 mils. Okay, it should be somewhere 2,850 mils. Now this 2,850 mils, this is the total amount of fluids that you are going to give in 24 hours. In 24 hours. This is the total amount of fluid you give in 24 hours. So these fluids now, it's not like you're going to give at once. So this is the fluid now. You can divide it either by 3 or by 4, depending on the number of hours you want to give. So if you want to be giving, let's say you want to be giving 8 hourly, you divide this by 3. So you're going to be giving 8 hourly. So remember, you divide this by 3 so that you give 8 hourly. Oh, isn't it? Every after 8 hours you give, every after 8 hours you give. So if you are going to be giving 8 hourly, meaning when you divide this by 3, you are going to be giving something like 950 mils every after 8 hours, 950, okay, mils. And if you want to be giving, let's say 6 hourly, you divide it by 4, meaning you're going to be giving 710 mils every after 6 hours, 6 hours. So that is how you are going to be giving the fluids. The fluid of choice is 0.9% normal saline. Okay, and as you treat, make sure you're monitoring the blood sugar levels. So blood sugar levels should be monitored every time and again. Okay, you monitor it every after 30 minutes, half hourly, you're monitoring the blood sugar levels. The moment that you see your blood sugar levels are falling to around 12 millimoles per liter, you are supposed to change the fluid that you are using from 0.9% normal saline. You are going to change it to DNS. Okay, you change it to DNS. The reason why you want to switch the fluids that you are going to give is because you want to prevent hypoglycemia. As you give these fluids and everything, the patient may go into hypoglycemia. So you want to prevent hypoglycemia. Okay, so that is how you are going to be calculating your fluids in DKA patients. We move to the next, insulin. How do you give insulin? How are you going to give insulin in these patients? So how do you give insulin? So insulin, how do we give insulin to these patients? So you are going to give soluble insulin. So you give soluble insulin. So you're going to give, what you give is soluble insulin, and you give it at a rate of 0.1 international units per kg per hour. So 0.1 international units per kg per hour, that's the dose of the insulin that you are going to be using. 0.1 international units per kg per hour. That is what you are going to be using in this patient. So how are you going to be giving this insulin to this patient? Remember, you've double cannulated, and one of the fluids that you are giving is supposed to have insulin. You give it as an infusion, which should run, you connect it to an infusion pump so that you know the rate at which it's going to be flowing. You set the rate, okay, the flow rate. So how are you going to do this? So what you do is you get 50 international units. Okay, when you get that valve, you withdraw 50 international units of insulin, you add it to 500 mils of normal saline. So you get 50 international units, add it to 500 mils of normal saline. This makes it, when you add here, it becomes 1 international unit. When you put here, it becomes 10 mils. So it's like you have, for every 10 mils that you withdraw from that giving set, from that 500 mils fluid that you have that's mixed with insulin, for every 10 mils withdraw, there's 1 international unit of insulin, right? So we've made an equation. Keep this equation in mind, okay? Keep this equation in mind. So now the next thing that you are going to do after you do this is you now calculate the dosage. So I'll give an example. Maybe if this patient is the same patient we had, 25 kg. Yeah, let's use the same patient, 25 kgs. Let's use the same. Okay, let's use a patient, let's say, who's 25 kgs. The same patient that we had. We can use the same patient that we had. So if the patient is 25 kgs, how much insulin are they receiving? So if they are 25 kgs, so what is the dosage of insulin that you are going to give? Remember, 0.1 international units per kg per hour, meaning 25 multiplied by 0.1. It's 25 kg times 0.1 international units per kg per hour. Remember that this is over, so the kg and the kg will go. So it's like 25 multiplied by 0.1. You are going to end up with 2.5 international units per hour. So you end up with 2.5 international units per hour once you multiply. So this is what you have. So this is what you want to give. Now, what we're interested in is, because this is mixed in a fluid, so we want to know how many mils per hour are we going to set on the giving set? Because on the giving set, you can put a rate, mils per hour, okay, in mils per hour, so that it's able to deliver a certain amount of mils in the patient per hour. So how many mils per hour are we going to deliver? So are we going to set on the giving set, how many mils per hour are we going to set, okay, so that we are able to deliver 2.5 international units per hour. Okay, so what we do is we want to know, to convert this to something like this. So if you have this equation, if 1 international unit is equal to 10 mils, okay, then what of 2.5? What about 2.5 international units? It is going to be equal to what? And this is going to be, this multiplied by this, it's going to be 25. 25 mils. This should follow per hour. So what you are going to set on your on your infusion pump is 25 mils per hour. Meaning, if the infusion pump is running at 25 mils per hour, if the infusion is running at 25 mils per hour, it means you'll be delivering 2.5 international units per hour in this particular patient, which is in line with the 0.1 international units per kg per hour. Okay, so now this is like the one you set. So you can even use this flow rate to calculate the drop factor, the number of drops that you are going to use in this patient if you don't have an infusion pump. So that is how you are going to do this. So this is how you are going to be giving your insulin. Okay, so now remember that as the glucose level, as your glucose falls, you are going to constantly keep on monitoring your blood glucose levels, as we said. Okay, and when your glucose, your RBS falls below 13.9, falls below 13.9, you are expected to half the dose of the insulin that you are giving. So if you started at 0.1 international units, you have it to 0.05 international units per kg per hour, so that you prevent hypoglycemia in this patient. Remember, when you are doing this side on the fluids, if you remember, you have also changed the fluid level. The fluid, just you've started running DNS in this patient. This is how we are going to calculate your insulin. Let's move on to the next principle of management. Okay, so what you have is on one side, you have two cannulas. That's why you double cannulate. On this side, fluid is running. On this side, your insulin is running in this patient. You are resuscitating. You are managing the DKA in this patient. Let's move on to the potassium. And again, another point is insulin. You shouldn't start the fluids together with the insulin at one time. At least you can administer some fluids, at least so that you hydrate the patient and then commence the potassium. Okay, the insulin. So the insulin and the potassium should be started a little bit later. Now the potassium replacement in this patient is important. Why? Remember, I already explained in the previous videos that this patient who has DKA, they have acidosis, meaning they have a high concentration of hydrogen ions in blood. These hydrogen ions are going to be exchanged for potassium, so that you get some hydrogen ions, you put it intracellularly so that you increase the pH, okay, so that the acidity of the blood sort of changes, okay, you lower the acidity of the blood, okay, so that it becomes more basic. So now, when you are doing that, as you do that, you are getting the potassium from the cells and putting it in the blood. And if the kidneys are functioning properly, what is going to happen is that you are going to end up in a state where the potassium levels appear normal in the blood, but then even if the potassium levels are appearing normal in the blood, as you start managing the DKA, you've started your insulin. Your insulin is going to stimulate the sodium-potassium pumps. You've started your fluids. They are going to change. Okay, the fluids is going to also going to help to lower the acidity. The potassium, the fluids. So it's going to start correcting. The diabetes is going. The DKA is going to be correcting, and the acidosis is going to. The ketones are now being flushed out from the fluids. Okay, and the insulin is also helping in taking up the potassium. So the potassium in blood will start to fall, and you may end up in hypokalemia. Okay, you may end up in hypokalemia. Now, when you end up with to prevent hypokalemia, you need to replace potassium. That's why it's important for you to do potassium replacement. Okay, so how are you going to do potassium replacement? So potassium replacement should only be done if the urine, you only replace potassium. Consider potassium replacements immediately. So commence potassium immediately unless you commence potassium unless the patient is anuric. You don't give potassium if the patient is anuric, meaning this patient is not able to pass urine. Because if the patient is not able to pass urine and you give potassium, it will accumulate and they'll go into hyperkalemia, which will cause peaked T waves on ECG, a widened QRS complex, prolonged PR interval. Those are some of the features you may see when you have hyperkalemia. So anuric, if the patient is anuric, okay, and you also don't give potassium if you have peaked T waves on ECG. You do your ECG, you find this peaked. Sorry, not this type of peaked. You have this peaked T waves. So if you find peaked T waves on ECG, it is indicative of hyperkalemia. Or if you have potassium level, if your potassium level is greater than 7 millimoles per liter in blood, 7 millimoles per liter. So in such a case, you don't commence potassium. Otherwise, if this is not the case, the urine output is okay. So you give fluids first, start off with the fluids, check the urine output. Your urine output is above 0.5 mils per kg per hour. you can commence them on potassium. And these things are not clear, you can commence on potassium. So you are going to be giving how much? So you give 20, you are going to give 20 millimoles of potassium chloride. So you give 20 millimoles of potassium chloride. This is added to every 500 ml of intravenous fluid that is given in the first 24 hours. So you add this 20 millimoles of potassium chloride to every 500 ml of IV fluids that is given in the first 24 hours. So that is how we are going to manage. And as you manage this, you are going to also be monitoring so that you don't send the patient into hyperkalemia. So that is how we are going to manage electrolyte imbalances. Okay, that's why you're going to manage. For acidosis, this one I don't even need. So for the acidosis, this one is rarely, if ever necessary. Correction of this is rarely or if ever necessary. So you need to continue. So for if the acidosis doesn't correct, as you resuscitate, this acidosis, the pH of blood should start to fall. If the acidosis continues, it would indicate that you haven't resuscitated properly. Insufficient resuscitation. Okay, so you can only consider the management with bicarbonate of this if they have severe, if the acidosis is so severe. Okay, but it's rarely necessary for you to correct. It corrects as you resuscitate. Antibiotics also, broad spectrum antibiotics. You can consider broad spectrum antibiotics. So the administration of proper antibiotics is guided by the results of the culture and sensitivity results. But starting empirical antibiotics on suspicion of infection until culture results are available, it might be advisable because one of the most commonest triggers of a DKA is a patient who is infections. So if you have an infection, that is one of the commonest triggers of DKA. Okay. So what are the complications of DKA? Complications could include cerebral edema. You can end up with hypokalemia as you try and resuscitate. Pulmonary edema, you can go into pulmonary edema. The patient can go into shock. They can go into AKI. All those are complications. Electrolyte imbalances, hypoglycemia, and arrhythmias as well. The arrhythmias can come in due to electrolyte imbalances as well. So all those are yeah. Then if a patient has cerebral edema, so a patient can develop cerebral edema, which is fetal. Okay, so mostly they may develop a headache, vomiting, or slowing of the heart rate in combination with an increased blood pressure, which is called the Cushing's triad. It may be seen in a patient indicating cerebral edema because the increased intracranial pressure may begin to increase. They may also have some changes in neurological status. Okay, in neurological status, maybe they may be restless, the child becomes irritable, increased drowsiness, incontinence, they may start having seizures, they may go into a coma. All those may indicate cerebral edema as the intracranial pressure increases. Okay, the other thing is certain specific neurological signs. For example, you may see unreactive pupils, cranial nerve pulses may also present, abnormal respiratory pattern, decorticate posture, all those things, and decreased oxygen saturation where patient becomes cyanotic. All those may point to cerebral edema. So if cerebral edema is suspected, when you see these features that I've talked about, you need to treat cerebral edema urgently. So reduce the rate of the fluid administration. So how do you treat it? Make sure you reduce the rate at which you're administering the fluids. Rate of fluid administration should be reduced, okay, by 1/3. So you reduce the rate of fluid administration by 1/3. Okay, that's one thing you do. Number one, reduce the rate of fluid administration by 1/3. Number two, you need to give mannitol 0.5 to 1 grams per kg, which is going to be given over 20 minutes. And you repeat if there is no initial response in 30 minutes to 2 hours. So number one, you are going to reduce the fluid administration rate by 1/3. Okay, reduce it by 1/3. The next thing is give mannitol 0.5 to 1 grams per kg IV over 20 minutes. You will repeat this in 30 minutes if the initial response wasn't good. Okay, in 30 minutes to 2 hours, you can repeat this dose of mannitol. The other principle you take is number 3, you are supposed to elevate the head of the bed. Okay, elevate the head of the bed if you suspect a cerebral edema, and consequently increase intracranial pressure would result. Okay, then you can also do a cranial CT scan Okay, this one should be done to rule out any possible causes of the neurological deterioration that patient may come in with. So that's just in a nutshell how you may want to handle a patient with cerebral edema. How do we know that DKA has resolved? So resolution of DKA, you can know it with the following. So normalization of serum anion gap. Remember that we said the anion gap becomes higher than 12. So serum anion gap may normalize to less than 12 milliequivalents per liter, and then the blood beta hydroxybutyrate levels. Remember that ketone body beta hydroxybutyrate? Its blood level may fall to less than 1 millimole per liter. The venous pH increases to more than 7.3. Remember that in DKA pH is below 7.3. It sort of reverses, increases above 7.3. Same as bicarbonate, which was below 15. It increases above 15 milliequivalents per liter. Then plasma glucose also, remember that it was above greater or equal to 11.1. In pediatrics, it's 11.1. It will fall below 11.1 millimoles per liter, and the patient may be able to eat at this stage. All those are indicators of the resolution of DKA. Now, how do you follow up this patient on the insulin part? So remember that this patient, you treated the patient and the patient is out of DKA. What do you do? So when you treat the patient and the patient is out of DKA, day one of the patient being out of DKA, day one. So day one of the patient being out of DKA, how are you going to do? So you are going to give this patient, to start the patient on short-acting or regular, which we call regular insulin, which are going to be given as 0.1 international units per kg per hour every 4 to 6 hours. So you're going to give 0.1 international units per kg per hour so you're going to be giving every after 4 to 6 hours. So every 4 to 6 hours you give 0.1 international units per kg. Every 4 to 6 you give this. This is given as subcutaneous insulin. So subcut. Okay, remember the previous one you were giving as an infusion, so you now start giving subcut insulin. So you need to be monitoring the glucose hourly. So hourly monitoring of blood glucose. If it cannot be provided, you may begin at half of these doses. If you can't monitor hourly, you need to begin at half of these doses. Okay, day 2. Now after this, day 2 now. This is where now you are going to start now the proper administration. You start now on your daily dose, the morning and the evening dose. So the dosage is 0.5 to 0.7 international units per kg. So that is the amount of insulin you are going to give. 0.5 to 0.75 international units per kg. That's your dosage. So 2 injections per day are given in the morning. So you are going to be giving 2 injections in the morning, which you call the AM dose, and the PM dose in the evening. Okay, so out of this dose, when you calculate using the weight of the patient, out of this, you are going to be giving 2/3 of your answer here, 2/3. 2/3 is given as AM, and 1/3 is given as PM. Okay, so that is how we are going to be given. Starting point to give 2/3 of total daily insulin in the morning before breakfast, and then 1/3 is given in the evenings before they take their evening meals. This is subcutaneous insulin that you are giving. I'll give an example for a 36 kg child. So a child was a weight of 36 kg. So if this child has a weight of 36 kg, if you start off at 0.5 international units, if you start off at 0.5, you want to start off at 0.5 international units per kg. So it says 0.5 multiplied by 36 kg, meaning how much is the total daily dose. The total daily dose that this patient is going to receive is obviously 0.5 times this is 18. So it's supposed to receive 18 international units every day. So what you are going to be giving out of this 18 that they are supposed to receive every day, you say 2/3 multiplied by 18 should be given in the morning, and 1/3 times 18 should be given in the evenings. Okay, and when you do that, you are going to find that before breakfast, you are going to be giving 12. Okay, so 2 over 3, you are going to be giving 12 international units. Okay, and then the remainder, 6 international units, you are going to be giving it in the evening. So in the morning, you are going to be 12, and 6. So what you do is, out of that, 1/3 should be short acting and 2/3 should be intermediate acting. So out of this that you've calculated the AM dose, 1/3, which is 1 over 3 times 12, is the 1/3 of this, okay, is short acting insulin. And 2/3, 2 over 3 times 12 of this is going to be intermediate acting. So again here, you do 1/3 short acting, 2/3 intermediate acting, which means that in the morning, you are going to give short acting 4 international units, intermediate acting 8 international units, total 12. When you come here, short acting, when you say short acting is going to be 1/3 of these 6, meaning your short acting, which is soluble insulin, is going to be 2 international units. Your intermediate acting, okay, which is lente, so intermediate is lente. Your intermediate acting, which is lente, is going to be 4 international units. So this is how you are going to be giving. So your daily dose is 0.5 to 0.75 international units per kg. So you get the weight of the patient, you multiply it by this. The answer you find, that is the total daily dose, which is your total daily dose, what you are going to be giving every day every day in this patient. Then 2/3 of this total daily dose is going to be given in the morning before breakfast, and 1/3 in the evening before lunch, before supper, dinner. Now, out of that 2/3, the 2/3 from here we calculated to say 2/3 is 12. Out of this 12, what you calculate here as 2/3, out of the dosage you give in the morning, 2/3 is supposed to be intermediate acting, which is lente insulin, and 1/3 is supposed to be given as short acting, which is soluble insulin. The same thing applies on the PM doses. So that is how you are going to be giving your insulin. So as you give your insulin, make sure you also educate the patient. Make sure you also educate the patient on the admission, because remember, one of the causes of one of the reason a patient to come in DKA is because maybe they were not on the insulin, they didn't know how to take the insulin, okay? They didn't know how to inject, they didn't know how to store the insulin, so that's maybe a reason as to why they come in DKA again. So make sure you educate this mother. So diabetes education should be delivered by a multidisciplinary pediatric, okay, diabetic team. Ideally, a doctor should be there, a nurse, a dietitian, psychologist, and a social worker. Okay, but in a lot of setups, you find that you may not have the luxury to have all these people, but your dietitian, as a doctor who's seeing this patient, as a nurse who's seeing this patient, make sure that you counsel these patients on diet, and make sure you link them with a dietitian who's going to guide them on the diet that they're going to be taking. Number one, because you're not going to resolve the DKA, the DM, the diabetes. It's not going to be well controlled with the diet. That is a major thing. If you don't deal with the diet, they'll come back in DKA again. The family should also know on how to store insulin. Insulin should be stored in a cool place, preferably in a fridge. But there are setups where maybe the patient they don't have a fridge. Okay, in communities, especially Zambian communities, there's what you call a josaka, isn't it? My Zambian people know. There's what you call a josaka. So this is the traditional thing that is made in the villages, which they can use to store insulin at a cooler temperature. Okay. So the family should also know how to inject the child. So injection sites should teach them in the technique on how to inject the insulin. You should educate them on this. Okay. The family should also understand the signs of hypoglycemia and how to manage it. Make sure you teach them on how to identify hypoglycemia, because it can shut down and it can kill the patient. It's a common complication of the treatment. The family should also understand the importance of regular reviews. They have to be coming for regular reviews so that the health of this child is improved. Okay. Apart from that, you should also make sure that before the patient goes, make sure you inspect the injection sites. make sure they are changing, advise them to change the injection sites. Okay, it could be the deltoid, you can administer on the deltoid, on the lower abdomen, on the thighs. So all those are some of the points you can inject. So, but they have to be changing the injection sites. Okay, there's what you call lipodystrophy. Okay, or it can even have an infection there, or there can even be an infection there. There can be ulceration. Okay, so you need to be changing the injection sites. You need to give this information to the patient. So this is how you manage diabetes in pediatrics. Okay, this is how you manage DKA in pediatrics. Thank you very much for listening up to this point. It's been a long video, but I hope it's worth it. I hope you've understood. Thank you very much for listening. If you haven't subscribed to the YouTube channel, please subscribe, because we're still posting more and more videos in all the departments. Okay, all the major departments in internal medicine, in surgery, and in pediatrics. We still keep on posting in obs and gyn as well, internal medicine, obs and gyn, surgery, pediatrics. Okay, so all these departments will be covered. So if you haven't subscribed to my YouTube channel, please subscribe to my YouTube channel, hit the like button, share with your friends, okay, so that you are able to see this content again. Okay, so thank you very much once again. May God bless you. Shalom, and let's meet in the next video. Thank you.